Hi, welcome to Pediatric and Adult TGCT Insights from the TGCT Support Registry. So during this webinar, all participants will have their mics and videos muted. Since it's a smaller group, please feel free to come off. Just know that if you do unmute or show your video, you will be recorded and that will go on YouTube. So if you would like the privacy, use our chat feature instead. There will be a question and answer session at the end of the presentation using questions submitted through that chat feature, and also will allow you guys to come off mute and ask questions. We also have quite a few questions submitted before, so we'll try and get through them all. My name is Sydney. I'm the director of TGCT programs at TGCT Support. I'm going to be the moderator and the speaker today. And we would like to thank our sponsors, EMD Serono, Decipher Pharmaceuticals, and Daiichi Sankyo for supporting our educational efforts. So thank you all. I'm going to be weird and just like go ahead and introduce myself. So my name is Sydney Stern. I have a PhD in pharmaceutical sciences and a master's in statistics and epidemiology. But really, why I'm here and why I do everything is because I have TGCT. And so, not too long ago, 6 years ago, we started TGCT support. I was diagnosed at 17, so I was a pediatric patient, and so the pediatric group is really near and dear to my heart. And so we can't do anything without doing it together. And so that inspired our attempt to go into both pediatric and adult TGCT in our registry. And so hopefully you can see my screen. I'm going to take that as a yes. If not, please throw a comment or a question or a finger or some hand motion up and let me know you can't see it. And so we're going to go through specifically our recent publication, and I'll draw conclusions on where you compare things with the adult registry. At any point, if you have questions, feel free to drop them in the chat or pop on unmute. It is me, so I'm also watching the chat at the same time, so I may miss something. But a brief overview. TGCT is a rare, it's locally aggressive. It originates in the joint lining, in the shock absorber of a joint called the bursa, or tendon sheath, which is a lining of a tendon to keep it from the nerves and everything being exposed. There are two distinct subtypes, the diffuse and localized form. These are things you already know, but just in case, these subtypes are determined by MRI alone. But really why we're here is that there's an unmet need in TGCT. Symptoms range from asymptomatic to debilitating, and recurrence is quite common. Due to the nonspecific nature of our symptoms, meaning they don't look like TGCT, they look like sports injuries, they look like swelling, they look like anything pretty much. But that makes it really hard to determine for providers at first glance that's what you have. And due to the rarity of the disease, patients may experience a significant delay in diagnosis, and we'll show how much of a delay in our data. So, what was this project? This project overall was used to understand how TGCT impacts pediatric patients and how do they compare to adult patients. Overall, the goal is really to determine if TGCT acts the same in these two populations, could we use some of the information we have for adults to advance the knowledge in pediatric patients? So, what do we know? We know that a large pediatric study was done in 29 children. These children were 3 to 11 years old, and it spanned 16 years. And it followed imaging and 1 to 2 year recurrence rates. And what we know is that the recurrence rates are pretty similar to adults from that study, but it was 29 kids. That's not a lot. An additional study in 2018 analyzed also pediatric patients. It used a meta-analysis, which means it looked at lots of studies all at once, and it found things that were similar between pediatric and adult patients. They looked at 76 pediatric patients from 17 reports, and they also found that it's quite similar, that TGCT in adults in pediatrics may appear the same. And so I was like, oh, we could totally do this on a bigger scale. And so no study to date had characterized the impact of TGCT in pediatrics, how it affects their quality of life, whether it's truly similar or different in adults, and highlight that patient perspective, which I think as a community is really necessary. And so we did that through this TGCT registry. If you're unfamiliar, It was initiated in 2022. It's a longitudinal study where real-world evidence is captured on patient-reported experience. So when you enter the registry, you would report your typical journey, who you are, your demographics, the burden of your disease, and parts of it that affect you. We did this from October 6th, 2022, all the way to November 26th, 2024. And we looked at 122 pediatric patients, all under the age of 18, right? Pediatric. So that's around 10% of our registry, or at the time of this cutoff. And then we analyzed the results from our already published data of 497 adults, which was recently published. And we just compared the two. So here's like the beef of it. Uh, what did we find? Who are these patients? And I see some parents in the group, so you may find your kid represented. We had 67% of the patients were female, and around a median age at diagnosis, meaning the middle number. If you look at all of everybody lined up, the middle number you found is that most patients were around 14 and a half. And then the when they enrolled, so at what point did they join our registry, was around 16. So we're looking at teenagers mostly. 50% are located in the United States, so we have great representation of everywhere pretty much. And when you look at different age groups, most of the children are adolescents, meaning that we don't have a lot of kids with TGCT that are between the ages of 2 and 11. Of course, we have 12 amazing patients that are that exception. Overwhelmingly, the knee was the most common, and when we look at the patient registry as a whole, diffuse TGCT is overrepresented. That's because we're just really good at finding those patients. That does not mean it's more common. So the localized form is actually the most common. Oh, look, I even made myself cute little notes. I'll have to remember the animations. So pediatric patients with TGCT, 62% of them are misdiagnosed, and pain is the most common symptom that leads to diagnosis. And when we look at the misdiagnoses in the large list, you see anything from Baker's cysts, which are just a large fluid pool in the back of the knee, sports injuries, genetic diseases, congenital abnormalities, rheumatoid arthritis, and oddly, generalized anxiety. We have never seen that with adults. And so I thought that that spoke to the fact that maybe when kids report pain, parents have to work really hard for it to be taken seriously. When we looked at who diagnoses these patients, patients are largely diagnosed by orthopedic surgeons, 65%. And more than 50% of pediatric patients are diagnosed more than a year after symptoms start. And I know from my experience that it was 6 years. So we're hoping that that changes, that patients are getting diagnosed faster than, say, 6 years when I was diagnosed. But I think that we have a lot more work to do there. So I think this registry really highlights that work can be done to expedite that time frame. How does this compare to adults? So adults, let's see. Oh, of course, animations. About half of all adult patients were misdiagnosed. Most of them are misdiagnosed with similar things, with Baker's cysts, with other sorts of cysts, sports injuries, arthritis, gout, sarcoma we saw in sprains. So similar stuff, but you don't see anxiety on that list, right? So that's something that's very specific to pediatrics. We also saw that the diagnosing provider is typically a sports surgeon, and adult patients also did not receive their diagnosis until much later, with 30% or so not receiving it for more than 2 years. So let's compare the two. The biggest thing that stands out is the misdiagnosis rate. Children with TGCT have a significantly higher misdiagnosis rate. It may be because they're seeing providers that may never have heard of TGCT before. It could be because they start with their pediatrician. We're not really entirely sure, but this is something that we can focus on with some of our efforts. Similar findings otherwise. Patients are typically diagnosed by sports surgeons regardless of what age, and it's typically quite a long time between onset of symptoms and actually the diagnosis. So the rest of those two, do I have a little, let's see, I have a pointer. So the rest of these graphs look very similar. You have 60%, 64%, so very similar findings otherwise, which shows us that maybe the paths can be similar. When we looked at misdiagnosis by diffuse versus localized, and I just wanted to show you what the science tables look like. I know it looks scary, but I'll walk through what this means. But when we look at misdiagnosis versus no misdiagnosis, just by subtypes, maybe diffuse patients are more likely to be misdiagnosed, or maybe they're less, and we wanted to know more. And so when you look at just the misdiagnosis, 63% of those with diffuse disease and 50% of those with localized are misdiagnosed. So it seems like those with diffuse disease are more likely to be misdiagnosed. And when we model that with a bunch of statistics, you actually get that patients with diffuse disease are 1.8 times more likely to be misdiagnosed than localized patients. This is an interesting finding, and it may just be based off education. The diffuse form is more rare, less common. But this, again, is another effort that we can now try and pursue. And when we look at adults versus pediatrics, unfortunately, as you saw just in the numbers, you had 50% of adults and 62% of kids misdiagnosed. It is what we consider statistically significant, meaning that pediatric patients are much more likely to be misdiagnosed, and that's not due to chance. There's something else going on. So when we look through the challenges, I love making schematics. So I'm going to walk you through my fancy schematic. But when we look at symptom onset, the main symptom that patients have is pain. That shouldn't be a surprise. Swelling comes in as a close second. And trying to get diagnosed, only 52.5% get diagnosed after a year. And so it's taking quite a while for them to get diagnosed. And majority of them are diagnosed by that sports surgeon. Only 20% are diagnosed by an orthopedic oncologist. And their pediatrician, rheumatologist, and other people play a large role in whether they get diagnosed with 14%. And we've already gone through some of those misdiagnoses, and we'll go through some of how patients are treating those symptoms or how parents and patients are treating those symptoms. But what's important to note is that large joint swelling is much more common in those with diffuse disease and less common in those with localized. But in general, pediatric patients are kind of overtreated symptom-wise, and we'll go into maybe why and some of that more of that information. But overall, what this lends itself to is likely the rarity of the disease, inconsistent naming, and the unfamiliarity of pediatric providers may contribute to all of these delays and some of this misdiagnosis. And so, what happens once you're actually diagnosed? Upon diagnosis, patients, I think I have, ooh, I always, um, pediatric patients, despite that long diagnostic history, in order to get to diagnosis, they're treated quite fast. You have, I'm pretty sure I have a skim. Okay. 61.5% are treated really quickly. They're treated all within 3 months. So they're pretty much having surgery immediately upon diagnosis. And unlike adults with TGCT that do get diagnosed by an orthopedic surgeon and then they switch to orthopedic oncology, it doesn't seem like that happens in pediatrics. When we look at pediatric patients, who's actually doing the treating is 80% sports surgeons. So patients aren't making it into those oncology centers. Here's another way of looking at it. Here's my cute little schematic of a pediatric patient. As we said before, 52.5% are taking more than a year to be diagnosed. They're mostly diagnosed in orthopedic sports medicine. And upon diagnosis, only a little over a third actually go to orthopedic oncology. If we compare to adults, here's my little adult. 56% take more than a year to be diagnosed, mostly by orthopedics. And when they are diagnosed, you see this huge switch, 62% switch. So that's quite a big difference. So I started talking about supportive care. We talk about like how patients are treating their symptoms. So not disease, just symptoms. And when we look at how many patients have had flares or a sudden increase in symptoms, you see that of the diffuse patients, 66% have a flare in the last 6 months, 67% in total. But this unknown subtype, patients that don't know whether they have localized or diffuse, they have more flares. And I can only speculate, but we mostly speculate that the providers of this unknown group may not actually know much about TGCT, and so management of their symptoms is poor as well. And so that's what this cute little blob says is that unknown patients with unknown disease may be seeing unfamiliar providers and their symptoms are just poorly controlled. And when we look at how patients are actually managing symptoms or how the combination of parents and patients, you see that patients with localized TGCT, this group right here, is using less supportive measures like analgesics, which would be like paracetamol or Tylenol, NSAIDs like ibuprofen or naproxen, nerve medication, narcotics, steroids, joint drains. They're just using these a lot less. Maybe because they're not as symptomatic, or maybe because they're having surgery and they're moving on. We're not entirely sure. But they're using these less. And when you look at the diffuse subtype, there's a lot of utilization of over-the-counter medications, as well as steroids, which may be because they're seeing sports surgeons. And so we know that steroids are not an effective treatment for the disease or symptoms of TGCT, but they're commonly used in sports medicine. And you also see that patients that are pediatric are getting a lot of joint aspirations, which is sticking a needle and just releasing the fluid. And we know that that fluid is likely to build up again, making it pretty difficult. Make sure I'm letting everybody in. Okay. So now when we go to treatment of surgery of any kind, it's no surprise that TGCT is often treated by surgery. So 82% of patients have had any surgery of any kind. And most of them have had arthroscopic surgeries. So 57% have that arthroscopic surgery. They're seen by sports surgeons. That makes sense. They do arthroscopic surgery, with a smaller portion having an open surgery. And when we look at systemic therapies, which means medications essentially for TGCT, that could be Pexy, imatinib, nilotinib, vimseltinib, although none of the patients were on vimseltinib for this cutoff because it wasn't approved yet. But what you can see is that 17% of our population of pediatric patients are on some medication for TGCT, most commonly imatinib. Thankfully, no pediatric patient has been treated with radiation. And a large portion of them at some point in their journey have paused and just monitored disease, like hopefully because they're not symptomatic, but it may be also due to lack of options available. I'm ahead of my little animations. When we look at treatments, and now we shift to the outcome of those treatments, patients are having a lot of surgeries when they're in their pediatric years. On average, patients with diffuse TGCT have 3.5 surgeries, and patients total would have 2.8 or close to 3. Localized may have 1 to 2 surgeries. And when we look at recurrence, sorry, I love my. You're forever gonna have to deal with my animations. When we look at recurrence or the outcome of surgery, how many of them have either symptomatic relapse or their disease is back or it's back on a scan? Um, Total, the recurrence rate is around 50%. For diffuse patients, it's 66%, so it is quite high. And I think what's important to see here is that many of those patients are on their second recurrence, meaning one surgery, if that's not effective, the second surgery is not more likely to be effective. So I think this really calls that we need more options for pediatric patients. I know I'm probably preaching to the choir here, but I think that this nicely highlights it, that subsequent recurrence was really, really high. So how does this compare to adults? This is a lot of numbers, so we'll walk through it. We have in green our pediatric. In this really pretty turquoise, we have the adult patients, and then you have localized, diffuse, unknown, and in the same order. And what we see is that overwhelmingly diffuse patients have arthroscopic surgeries, keyhole surgeries, much less in the adult population. So it's overutilized by pediatric providers. Open surgeries are fairly similar. Uh, and the use of medications or systemic therapies is similar. So if we look at diffuse disease, 23% of our registry are on these drugs. Similar, 24% of our diffuse patients um, in our adult population are. So these are very similar numbers, similar utilization. but none of these drugs are approved for pediatric use. So we're hoping to an unintended consequence of this registry is to raise awareness that the study should be conducted in pediatric patients, and that there's a need for these drugs in these patients, and maybe even some risk tolerance to putting these drugs in pediatric patients. Um, and then when we look at recurrence rates of pediatric versus adult, it's quite high. Patients, when you look at those who've had multiple surgeries, the recurrence rate goes up to 77% for pediatrics and 71% for adults. So just repeatedly going into the joint is not effective. So, looking at the burden of the disease, as we said, the most common symptom, regardless of the subtype, is pain overall. 94% of patients reported pain at some point. And pediatric patients report that this pain interferes with their ability to enjoy life, 80% of them. And 83% say it impacts their ability to have fun, to do fun activities. Um, Patients reported that their TGCT impact their ability to do sports, to plan their future career goals and in school choices. One thing that stuck with me is that a patient who was old enough to fill out the registry himself or themselves, they reported that they were intending to join the military, but that they would never pass the physical exam now. And so several pediatric patients mention how much TGCT impacts their ability to focus on school or relate to their friends or even interact in the future with what they'd like to do. And so it just shows how impactful it is. All patients with the pediatric TGCT reported at least one symptom, including pain, swelling, limited range of motion, or stiffness. And then more than half of patients said that the pain or physical function impacted their ability to participate in daily life. This is how we establish a significant need for treatment. And so through this data set, we came up with a potential paradigm for treatment. And so we'll walk through this and then I'll start answering some questions. So when an MRI is suggestive of TGCT, and that would be classified as diffuse or localized by MRI alone, patients could be assessed by symptom status. If they are asymptomatic, the recommendation currently from global consensus is just to monitor. Consider biopsy to confirm the disease, but monitor with routine follow-up. That's because you don't want a pediatric patient with 3+ surgeries by the time they're 18. It's just a lot of impact on the joint. For if patients are symptomatic, then localized or TGCT that's completely well circumscribed or well defined that you can essentially draw like a border around, that one can be removed. If you're diffuse, then it should be an immediate referral to an orthopedic oncologist, um, where it could be assessed for disease that is inside the joint or outside the joint. So intra-articular means inside, extra-articular means it's outside that capsule. It's like in the back, in the muscles, it's elsewhere. And that's typically a sign that it's going to be really difficult to remove. So if it's inside the joint, it's a little bit easier to remove. And if you can completely remove it, that's what we call macroscopic complete resection. That means you can remove it all. If that can be done with low complication rates, low chances of disfiguring, it should be done. It can be done as an open or it can be done as a scope. There's a lot of current controversy on which one's most appropriate, but an orthopedic oncologist and a multidisciplinary team should be part of that discussion. If it cannot be fully removed or removing it would cause a lot of damage, then it should be referred to a medical oncologist. And so medical oncology would be over here. Similarly, if the disease extends outside the joint, is all over the place in muscles, it should be referred to a medical oncologist as well. In that case, considerations for these CSF1 inhibitors, either before surgery or instead of surgery, could be considered. And if patients have a complete response, meaning there's no more disease because of the drugs, they could consider going on a holiday, meaning they go on a break, or they re-challenge if they develop symptoms. A partial response or someone that doesn't have all their disease gone, maybe they go to surgery, maybe they just watch. That kind of becomes the question mark because we don't have a lot of data. Okay. But what are the takeaways of this? The sooner a patient gets to multidisciplinary care with the expertise in TGCT, the better. That is excessively difficult in pediatrics because pediatrics see the disease less. So if there are teams that see young adults or adolescents and young adults, they would have more experience in pediatric TGCT or in general TGCT. And so pediatricians and orthopedic oncology or orthopedics play a larger role in the management of TGCT in pediatrics, more so in pediatrics than adults because they're rarely referred to oncology centers. And most pediatric patients with diffuse TGCT have multiple surgeries before they become adults. And there's no approved drug currently for TGCT, but these medications are still being used. And so it's really important that we develop an understanding of what dose is appropriate, how these should be used in these patients, and whether these drugs actually work and or are safe, right? We don't have that information. We just surmise it from the adults. Part of showing that the adult population is similar to the pediatric population is showing that these drugs will likely work in those populations, but we don't have the data. What we did find is imatinib was most commonly used, and the doses used in both imatinib and pexidartinib were the same doses as the adult population. So drug development should consider whether including pediatric patients would be really helpful. And in general, what we found is that there's a high unmet need. It's a similar disease. It's a similarly high recurrence rate, and so they should likely be included. And so thank you. I will stop sharing and we can start talking and taking questions. I see one already in the chat. Um, yes, yes. So someone had asked whether in the questionnaire or the registry if we could differentiate whether there's patients that wait to treat or whether they're waiting because they have no other options or insurance or they're not symptomatic. And I agree. I think we can get more granular about why they're actively monitoring their disease. Another question, have any of the trials enrolled TGCT patients that are pediatric? That's a good question. As of now, the only one that included pediatric patients in their enrollment, so we don't know if they've actually had any patients, was emactuzumab. Emactuzumab is a injectable protein-based drug, which means that it's injected every 2 weeks for five total injections, so 10 weeks. And then they're currently seeing whether it shrinks the disease, how patients do after. That data hasn't been released. So we don't know if they actually enrolled any pediatric patients, but they included those down to 12 years of age. If they enroll any, that would be the first step. There's also a study going on by the NIH. That NIH study is enrolling patients with for pediatric TGCT with pexidartinib. So Tralio is a brand name for that. And they will give the Tralio to patients and monitor and see if the doses are the same. So that's a study that's currently being done at the NIH. You would have to fly to the NIH. But if there is any interest in that study, I would happily share the information and so my email is in the chat if you're interested in that information. Any other, oh, thank you. So why do I think that pediatric patients are referred less to oncology? Um, I think it's a case of we don't know what we don't know. I think often in the space of rare diseases, providers don't know that there's other options available. And so similar to adults, referring to a oncology center is not well known. I think also the naming PVNS causes it to be treated like a synovitis and not like a tumor disease. And so if you're treating it like a synovitis, that's something that sports medicine physicians would see. They wouldn't see necessarily tumors. And so I think that naming is also holding pediatric patients back from being seen. But that oncology center, like pediatric cancer centers, they don't see TGCT that often because they're not seeing adults with TGCT. So I think it's that sweet spot of the adolescent young adult population that does really, really well and they have a lot more experience. But those sites are far and few between and they're often adult centers. So I don't think that pediatric patients or their parents would know, oh, let's go to an adult cancer center for this. Please feel free also to come off mute if you'd like to ask a question too. I gotta get background music. Doo doo. Someone asked, are pediatric patients receiving the same amount of drug as adults? And from our current data, yes, there's no difference in dosing. I'm not sure if that's because that's just what's available, and that's stuff we know versus what's truly useful for patients. I think dosing is something that's needed. But yes, they're currently receiving adult doses. And from early data, there was a small study done with um, pexidartinib that showed that it could be the same data, that PK could be, or that the pharmacokinetics, like how the drug goes through the body, and is the same in a pediatric patient as an adult. And so those doses may be adequate. We just need more data. Someone asked, is there fertility concerns with medication and ethical issues with preserving fertility in children? Someone could give a whole webinar on that one, I think. So I'll start with the easier one, ethical issues with preserving in children. For that one, cancer centers do offer fertility preservation in those post-pubescent, so those after um, puberty. That could be like sperm banking for post-pubescent boys. For girls, it's a little bit more invasive. It's like oocyte, which is egg harvesting. Um, and for those prepubescent, for boys, there's not a lot of from my understanding, there's not a lot of known things they can do. They can take testy tissue, but it's investigational. For prepubescent girls, they can also take tissue from like reproductive organs, but that's much more invasive too. Thankfully, from our data, most patients are diagnosed after the age of 12, which is typically when puberty is in full force for anyone that has a 12-year-old. So that's typically not as much of a problem, but it's definitely a worthy consideration. And a lot of patients, I think, even young adults are preserving or doing fertility preservation just to not have also a time constraint on when they have family planning. But it's a worthy consideration and often a discussion between a multidisciplinary team. For the harder question of fertility concerns with medication, in general, there is just a lack of information regarding medications in fertility because you can't give a bunch of pregnant women or people, males trying to have children, you can't give them all these drugs and then say, try it, right? That's the ethical concern. So you have to wait a long, long time to have observational data captured. And so that data just doesn't exist. These drugs are fairly new. From animal data, things appear reversible. And the doses that do affect fertility, we'll just use like vimseltinib for an example, because I was just looking at their data. Um, that a lot of those doses that would cause like testicular atrophy in animals tend to be 6 to 12 times the dose you would have as a human. So how relevant that is hard to say. But it's a worthy consideration to discuss with your clinician and with your team about whether these drugs are appropriate and when they're appropriate, whether fertility preservation gets rid of those concerns. Um, we do have a lot more data on imatinib in general, and so imatinib's been used in pediatric populations, and I think in general it's the preferred when fertility is really a concern. But none of these drugs are approved for those under 18. And for imatinib, it's not approved for TGCT. So a lot of this is fighting with insurance companies. It's talking to clinicians about their personal experience. And so it's really important to have a team that has a lot of experience. Any other questions? I always blow through slides too fast, so I can go over anything and go back as well. That's a good question. If a patient doesn't have an orthopedic oncologist in their area, can they be helped by seeing orthopedics who practice at a hospital that is affiliated? Um, Yes and no. So there is something called tumor boards. This is where doctors, like orthopedic surgeons, may present their case. And based off of big experts in the field that sit on this board, you can have a discussion about what's the best thing to do for a patient where you wouldn't have access to a large center. We host those tumor boards. And so if there are patients who are like, this isn't feasible, right? I can't go to a large center. Then if their doctor is willing to present their situation, then the tumor board can provide comments and they can get some impact from like really large experts or some of the big ones. But otherwise, a lot of patients do have to travel. It's really difficult, and the feasibility of that and financial issues that go with that is weighs on patients, I think, in general in rare diseases. Some orthopedics that don't have the same expertise may reach out to colleagues. The issue is that orthopedic surgeons, it's not really an issue, but they specialize in arthroscopes. They don't specialize in open procedures typically. And so it's an entirely different technique. So they may be able to get advice from other providers, but they shouldn't suddenly do a procedure that they've never done before. So ideally, they could still be referred to a cancer center nearby, and that cancer center could work with an expert team. But it's not always feasible. And in that case, my recommendation is always email us and we will help you get as much expert care as possible. But it is a known issue, I think, in general, and with rare diseases that they're just so spread out that experts are so hard to come by. And so I think pediatrics is, if not harder, it's definitely felt the same. Oh, someone asked, okay. So, yes. So someone asked, I am a pediatric, or I was a pediatric patient. I'm long ago a pediatric patient. And I was seen by orthopedic surgery. So when you see those little tables, that's pretty much my journey. I was seen by orthopedic surgery until I was 21, and then I sought care from a academic multidisciplinary orthopedic oncologist and medical oncologist team. But it was sought after. I don't think any of the pediatric providers that I knew or saw, and I saw many of them, they didn't really know anything about the disease. They had never really heard of it. Or if they had heard of it, it was very like nonchalant and dismissive. And so I think that's what ends up happening with a lot of patients. They age out of pediatrics and then they find better care. But we have to care for our little ones, right? Like I don't think that that's a reasonable path. So I think we're working on that. But I think my story shows that experience as well. And hopefully it's been 11 years since I was diagnosed, so hopefully it's getting better. Right, I was diagnosed or it took me 6 years to be diagnosed. It's taking people 1 to 2 years now. That is a shift. So hopefully that continues to shift. Oh, and I realized I put my email not in the general chat. So I will put it in the general chat for anybody who's interested in those tumor boards or anything similar. Well, if there are no more questions, I will not hold you hostage. We can end early. But please feel free to email me any questions. Thank you, everybody. Oh, thanks. Thank you.